think we got it. So, welcome to my knowledge, the first CSA COVID-19 webinar hosted by your Young Surgeons Committee. Very happy that all of you guys could join us tonight. I think we're probably all Zoom experts by now, but if you can mute your microphone when you're not talking, make sure the dog isn't going crazy in the background. It's nice when your camera's in the right position so we're not looking at bald spots, you know, like this. And then I think most people know how to use chat functions and other things like that. You guys would all certainly know what the CSA is, or you wouldn't be here. The point of this is to capitalize on our best asset, which is our people that come together and make this organization so great. And you guys already know that, or you wouldn't be here. Quick public service announcement. We're always looking for new members, and that is actually going to be one of the topics that we're going to be discussing tonight, of the effect of COVID on surgical memberships and things like that. But if you know of anybody, the membership team is always looking for people. We have contests to see who can recruit the most, and your reward is a lot of gratitude. And Scott Melvin will buy you a drink at the bar at the annual meeting. That's your punishment for being there. You go. So here's how we're going to do this real quick. This is the introduction. I'm then going to ask all of our past presidents to please introduce themselves. And so if you could introduce yourself, where you are currently and what your practice is, what year you were CSA president, and what was your first year attending a CSA event. And we'll go from there. After that, after everybody introduces themselves, we're going to do our preliminary polls on our controversial topics. Everybody's going to vote using the Zoom function. We will then have our breakout rooms where we discuss each topic. We will then come back and discuss what we had in our breakout rooms. We will re-poll the group and see if anybody changed their minds. And then we'll conclude, hopefully, with some feedback and ideas. Should we do something like this again? What other ways, what other good things can we do for CSA? This would not have been possible. This is the best committee that I've been on in any surgical association. I really thank all you guys for being on the phone calls with me, putting up with my stupid ideas, things like that. I really hope you guys get something out of this and the wisdom of the other people. The other people who aren't in this slide that need to be are LK and April and their group. I can't tell you what a pleasure it is working with you guys and what professionals you are. So much thanks to you guys. And without further ado, we're just going to go with the list that we have here. I'm going to mute my microphone, and then Dr. Bell, if you could kick things off. And then if you see your name next on there, Chris, if you could go after Dr. Bell is done, and we'll go from there.
Thank you, Chris. I'm glad you showed this slide because I couldn't remember what year I was president of the Central Surgical, but it was 2009, I see. I had finished up a stint as chair at Northwestern from 2000 to 2006. And then for the last few years of my career, I moved to Philadelphia and worked for the American Board of Surgery on the SCORE curriculum project. And I'm looking forward to tonight because it's always been a pleasure for me to interact with young surgeons and surgeons starting out their careers. That's been a source of great pleasure. Thank you.
I'm Chris Ellison. I was president in 2008 during a blazing snowstorm in Cincinnati. I think you'll all remember that, whoever was there. I think my first event was in the 1980s. And I have great friends through the Central Surgical. I think it's one of the best surgical associations in the United States. And I love it dearly, and go to every meeting that I possibly can. Thank you.
I'm Jerry Freed. I was president in 2012. And like Chris, my president year was in Madison, Wisconsin during also a snowstorm. It is, I guess, it's characteristics of having a meeting in the Midwest in the middle of winter. I joined the Central. It was the first specialty organization that I joined in the early 1980s, and my first paper was delivered there as a resident, or my second paper, I should say. I met many, many friends over the years, many of whom are on this call, because the organization is really designed to build relationships. It's not too big. People are friendly, and the meeting is really first rate. I'm at McGill University. I was a chair for 10 years, and now I'm serving as Associate Dean for Educational Technology and Innovation and Director of our Simulation Center.
Okay, I can't see my participant list anymore in my presentation mode. Is Dr. Gruber on?
Dr. Gruber is the only past president we are waiting for. So Dr. Lucetti, if you'd like to introduce yourself next, you're more than welcome to.
Well, thank you very much. I hope you can all hear me.
We can.
And worse, you get to look at me too. Oh my God. I am currently at Loyola University Medical Center in Chicago, Stritch School of Medicine. I've been here 19 years now. It's hard to believe. And shortly after I relocated to Loyola, I had the pleasure of meeting all the people listed here as past presidents through the Central Surgical. My first meeting was in 1989. It was I was fortunate to be in the Department of Cincinnati at that time, where Joe Fisher was, who was a past president of the Central. He was obviously instrumental in getting me into the organization, and the rest is just history. It is hands down my favorite organization. As I think several folks mentioned, it's small, it's intimate, you meet all types of surgeons, transplant surgeons, you hear state-of-the-art science at the annual meeting. And it's just good people that you can rub elbows with, and it's a great organization to network with. And I'm very much looking forward to the evening. This is a great idea, Dan. Thank you for putting it together.
Hi, I'm Mark Melangoni. First, kudos to Dan and everybody else for your hard work at making this go. I was president of the Central Surgical in 2005. I was lucky enough to have it in a warm weather location. We actually were in Tucson, Arizona, where one day the high temperature was 45 degrees, but we didn't care because the sun was shining. I'm in Cleveland, Ohio. I'm a retired general surgeon that practiced at Metro Health Medical Center for about 21 years. And like others have said, Central Surgical is just my favorite, and I just look forward to seeing everybody every year. I've been to every meeting except one since 1981, and hope that streak will continue.
Hello, everyone. I'm Chris McHenry. I was president of the Central Surgical in 2015. And I think my first meeting or presentation at the Central Surgical was in the very early 1990s. I am an endocrine and general surgeon. I practice in Cleveland, Ohio. I'm at Metro Health Medical Center, where I am getting ready to finish my 31st year at a single institution. And as others have mentioned, I'm very, very proud to have been to continue to be a part of such a great organization as the Central Surgical Association. And I'm happy to be here tonight and looking forward to this event. And again, like to echo my thanks to Dan for putting this together.
I guess I'm next. We're going in alphabetical order. My name's Scott Melvin. I was the president in 2017. And I think the example of mentorship is important because Dr. Ellison brought me to my first meeting in 1994 when I had first joined faculty at Ohio State. We still have some allegiance there because if you notice, Jerry Freed was wearing a Buckeyes sweatshirt. For those of you who don't know, they were the runners up. They were the second place team at the Ohio State at the national championship.
As usual.
Yeah, I didn't see Iowa and Northwestern there at all, but they were. I'm in New York now, still a member of the Central, and I'm very proud to be part of the organization and continue to be active. I still try and recruit people and recruit papers from New York City. Thank you.
My name is Dave Mulder. I'm from McGill in Montreal. I grew up in Saskatchewan, did my general surgery in Montreal, my thoracic surgery at the University of Iowa, another central surgical. I guess my first experience with presenting a paper was I was introduced by Dr. Gerd, and we prepared a paper on massive GI hemorrhage, and Jack Pickelman took me apart. It was an unbelievable experience, but very positive. I learned an immense amount. And like everybody here has expressed, the Central is a very popular meeting for both myself and my wife. And my wife commented tonight on what a tremendous group of wives the Central Surgical had. So it's a really very important social engagement, and I've enjoyed every meeting I've attended.
I'm Michael Nussbaum. I was president in 2011. My first meeting that I attended was in 1992, and I don't think I've missed a meeting since. I spent most of my career in Cincinnati, and Joe Fisher was my mentor, and the Central Surgical was very important to him, and it was a key thing for all the faculty to be involved with, and I'm so glad that I've been a member for all of these years. I was local arrangements chair for the 2008 meeting that brought the snowstorm that grounded lots of people in Cincinnati. It did give Dick and Mimi Bell and my wife and I additional time to be together because they couldn't get out of Cincinnati. And after that, I decided to move to Florida and extended the reach of the Central Surgical down to Florida. I was in Jacksonville for 9 years, and now I am in Roanoke, Virginia at Carilion Clinic in Virginia Tech, and just happy to join this group of colleagues and welcome the young members.
Hi, I'm Margot Shoup. I was the president of the Central Surgical in 2019, and I am very proud of Central Surgical that year because it became the landmark year where we actually had the first woman president of the history of the organization. And not only that, but we subsequently had back-to-back women presidents, and we're really excited that Tina's here too. I joined the Central Surgical very early on in my career, I think around 2004. And I actually first presented at the Central Surgical in the 1990s during my residency. I lived in Chicago for actually about 30 years, if you include medical school, all the way until the time we left Chicago, and practiced at Loyola, and then also in the western suburbs of Chicago for a number of years in community practice. I'm currently in Connecticut, so I'm probably the easternmost person in the Central Surgical, I believe. But I am in the backyard of Dr. Melvin because I'm in New York and Connecticut as well. And it's really been an honor to be not just a member of the Central, but to really get to know some really phenomenal people. And when people ask me who my mentors are, I say, just look at the presidents of the Central Surgical, and that'll explain it to you right there. So thanks, Danny, for putting this together. We're looking forward to a fun evening.
And good evening, everybody. This is Nat Soper. I first went to the Central Surgical in the early 1990s and talked something about lap chole or something like that back in the day. And I've been to multiple Central Surgical meetings since that time. I was president in 2014. I got onto the list of people who would be potentially in line with being a president because of Dick Bell's influence. And again, he was a mentor of mine. I subsequently joined him at Northwestern University in Chicago, where I was the chair for 12 years. And recently I moved down to be the furthest southwest person in the Central Surgical. And currently I'm in Phoenix. And this afternoon I was out feeding hummingbirds on my deck in 75-degree weather. So I'm not missing Chicago at all right now. I agree with many of the others who have talked about Central being a wonderful place to be grounded. I have many, many good friends there, but it's a great organization because the meeting has all kinds of general surgical presentations as opposed to the specialty organizations that we all are members of. So this is one that I really push the junior surgeons in the faculty to join because they get to meet individuals like all of the other presidents here and get to present papers, and it's presented in a great journal. So this is a wonderful organization. And Dan, thank you for taking this presentation on this evening.
Hi, I'm Tom Stellato from Cleveland. The hummingbirds have left Cleveland, but the pileated woodpeckers are on our suet feeder every day, and I don't think you have those, Nat, out in Phoenix. I was president in 2007, but I've been coming to the Central since the early 1980s. I've spent my entire professional career in Cleveland at Case Western Reserve and University Hospitals. I was division chief at University Hospitals and got my MBA in year 2000. And currently I'm now slowing down, working a couple days a week at our VA here in Cleveland. It's great to be here.
Last but not least, I'm Tina Yen. I'm your immediate past president. I'm a surgical oncologist by training, focused in breast and endocrine surgery. I've been at the Medical College of Wisconsin since the mid-2000s. Actually, don't remember what was my first central meeting, but I do remember I had to present on a Saturday afternoon to about, like 5 or 10 people. And I was like, what is this? But I think I've been to every meeting since. It's been a wonderful opportunity, as everyone has kind of already talked about how intimate of a setting it is, and being able to meet a bunch of people that may not be in the disciplines that you practice have provided great opportunities for myself and hopefully for many others to grow into leadership positions. And as we know, the 2020 meeting was canceled, but we are trying to move the annual meeting to a warmer time of the year. So hopefully June-ish from here on out, whenever we can have another meeting. And thanks to Danny for putting on this this webinar. We had initially planned to do this as a panel session at the 2020 meeting, and Danny and his team thought it would be a great idea to still carry it out, but in this format. So we look forward to a great evening.
Thanks, Tina, and I appreciate your leadership in letting me try this at last year's meeting that didn't happen, and trying something new. So much appreciated. Well, I got to be honest, that was a lot of fun just to listen to your guys' stories and hear your passion for CSA. So let me tell you what's going to happen next. As soon as I advance the screen here, you're going to start seeing polls on there. There are 7 poll questions, and LK is going to launch it, just what you see there. Make your vote and then hit submit, and we're going to do all 7 of these before we go to the breakout rooms. So it should be live and up there. Click 1 and hit submit.
We're doing good so far. We've got about 80% of people have voted so far, and our agree disagree bar is going back and forth, so it's close at the moment. So get your vote in there. All right, I have looks like mostly everyone has voted. Oh, one more person. You could do it. All right, I'm going to end the poll and we're going to launch our results. Share results. So we have 41% agree.
Interesting. All right. And just so you guys know, while we go to the breakout rooms, LK has made slides after this where we'll be able to see the pre and the post polling on there. Okay, here comes, I'm going to advance 1 slide. Here you go. And LK will launch the poll.
Okay, and we should be able to see poll 2 now. Oh, this one doesn't look competitive at all. We have about 84% of the votes are in. All right, we have everyone 100% voted. So I'm going to end this and I'm going to share the results.
Okay, I'm not sure who's assigned to room 2, but you might want to start thinking about something else to talk about. There may not be a ton of discussion there. Okay, I'm going to advance 1 slide here. Okay, there we go.
All right, poll 3 is live. All right, this one's going back and forth, so this one will be a good discussion in this room. We have about 90% of people have voted. A few more people. Perfect. Everyone has voted. Share results.
Interesting. Interesting. Okay. Here we go.
Okay, poll 4. Well, this will be a good conversation in this room. My bar is going, it gives me an update as it's launching and the bar is going back and forth. All right, everyone has voted. This one's close. This will be a good conversation in this room. Share results.
Wow. Interesting. Okay. I look forward to hearing back from room 4 once we break out. Okay.
Yeah.
Let me advance one slide. Here we go.
All right, we got 30% of people voted. Everyone's getting the hang of this. We're going faster. This is good. 96% of the votes are in. 2 more people. All right, nice. Share the results.
Not what I would have predicted, but okay. All right, let me advance one here again. There we go.
Launch. And hopefully if people agree that there's a decrease in surgical associations, they're not willing to leave the central. That's other groups.
Maybe we should have worded that differently. There'll be a decrease in everything but CSA.
All right, 93% of our voters are in. Few more. All right, I'm going to end the poll. There's one more person to vote.
Come on, don't be that person.
Oh, share result.
Okay, I think that's my room, so I look forward to being in there with you guys. And then here is the
Wait, can the people from Chicago vote more than once?
And there we go.
Always, Mike, always.
Oh boy, so far we don't have just any, oh no, we've got a few opposing views now. I wish you guys could see live at the same time how the results are coming in.
48, 40.
Oh, I should pause the recording. I don't want to forget. Okay, now we're recording again. 28 seconds and then all the breakout rooms will arrive back. How was the conversation in your room so far?
Great.
Good.
We had a lot of fun.
Nice.
Fun is good.
You guys had a smaller group, so you guys probably had a really good conversation.
It was nice and real. It was the Chicago connection, you know.
Nice.
It worked.
I actually think rooms like that probably did better than some of the larger rooms. All right, I think we have everyone back now.
LK, am I still screen sharing or do I need to go and do it?
You can pull up your, no, April can pull up the slides.
Okay, are you seeing them now?
Yes,
Yeah.
we see your screen. All of April
Okay.
pull them up though, because then we're going to do the discussion.
Gotcha. So we are ready for group discussions. We are ready for room 1 to report back to us of, whoops, I screwed up. Did you just take the screen away from me? There we go.
Did. That's fine,
Oh.
you're good.
No, perfect. Gotcha. So here was the first vote. Who was our room 1 representative?
All right, well, this is me. So the discussion is about remote surgery. I think the first thing we talk about is what's the definition of remote surgery. But I think it's that there's a pros and cons. I think in summary, I think the group has hesitant about saying that we would think that it would happen in 10 years, maybe 20 years. The reason is because there's a lot to overcome. There's a lot of barriers. For example, licensing issues, the technology issues. There's a patient acceptance issue as well as to be able to do remote surgery. We need to have the capability at the remote site as well as the personnel to able to take care of the complications. So if we're able to overcome those obstacles, it may happen, but we don't know if 10, 20 years is sufficient. So that's the summary of the group.
Got it. Thank you. Okay, you ready to, do you have the polls launched as we go each one, or are we doing them at the end?
I can do them either or. How would you prefer?
I think I'd rather do it now because it's fresh on. I'm not going to remember what poll 1 was by the time we get to the end.
Sure,
So
I'll do it now.
there we go. Everybody vote.
So did we change anyone's mind? All right, we've got 81% of our voters are in. A few more. One more person. Oh, come on. You could do it. All right, I'm going to end the poll. Share results.
So maybe we changed one person, or was one person less voting, but I don't think we moved the needle too much on that one. Interesting. Okay, let's go on to room number 2.
Okay,
And who is is that you, Zara?
It is me, yes. So this is our room 2. You know, this was the poll that pretty much everybody agreed that virtual visits are here to stay. I would love to hear from whoever this 9% who disagreed. I would love to hear why. But certainly in our little breakout session, we discussed how pre-COVID virtual visits may not have been very established in many practices and to some extent in some others, but really COVID has set the stage for virtual health, and we have learned a lot that we will take with us to the post-COVID era. We talked about some of the challenges like the eyeball test or physical examination, and really from a surgical perspective, from a surgeon perspective, maybe there's some things in terms of innovation or technology that we can bring with us. So although it may be more applicable for medical specialties or ideal for patients with chronic diseases, but certainly there is a role for us as surgeons, especially in our initial discussions and setting the stage for the different options that our patients can have, seeing patients that are from out of state or are coming from long distances. A couple of other things we talked about that were interesting is looking at it from a patient perspective, how it has a lot to offer for the consumer. Going to the office can be frustrating. Patients don't need to commute, they don't need to park. We reduce the cost of that. You know, while they're waiting for their virtual visit, they can do some things at home and get some things done. And one of the other interesting things we talked about is how does this impact resident education? And we felt that we can really incorporate that, and certainly, you know, we can incorporate the residents in this in our discussions and seeing the patients, and really there is something for them to learn through that interaction. So I'll bring it back to the group, and I'd love if whoever had the 9% would volunteer and tell us what they think before we go back.
I guess the way this question is posed, are they here to stay? Yes, they're here to stay. Are they a necessity? That's, I think, a question that is debatable. Certainly for medicine, I would agree that it has much more value in medicine than it does in surgery. At the VA, we were being pushed to do as many virtual telehealth visits as possible. And a significant number, majority of those patients end up having to have a face-to-face visit. As surgeons, you know, I think that they're here to stay. How much of a necessity they are is another question.
A great point.
You took the words out of my mouth, Tom.
Great point.
All right, thank you for, that was the whole idea of this stuff, was to get ideas bounced off of each other. Let's vote.
A few more people trying to make up their mind. We have 93% of the vote in.
Can I just make a comment while you're pulling that up?
Absolutely.
So, I mean, I think, Tom, you're exactly right about, you know, for seeing patients and assessing surgery and discussing indications. I mean, those are going to be in-person visits, but there's a lot of other areas within surgery where telemedicine makes a lot of sense. I mean, I basically do every one of my lap chole follow-ups now telemed. I hardly have anybody ever come back in person. And for people that live 3 or 4 hours away, it's harder for them to get here. We do a lot of the post-operative visits, especially when you're focused on patient-centered outcomes and you're doing things in a minimally invasive fashion. It's not so important to necessarily see the wounds and that sort of thing. So I think it's been a source of great patient satisfaction as well to be able to do a lot of these. People don't have to deal with the parking, coming into the clinic, the drive, taking a day off work. I think it's really terrific for surgical practice from that perspective.
Yeah, I'll add to that. We see patients who come from hours away. We have a large rural population. The other thing that we've established is these patients go to their primary care provider in their local town, and we do the virtual visit there where there's an advanced care provider there who can examine. If we want them to be examined, they can examine the patients and we can still have a remote surgical visit with them. So it's really, it's opened up a lot. And the other part is, in the past when we've talked about televisits was how do we get reimbursed? And with COVID, the payers have agreed to reimburse us for both telephonic and virtual visits. I don't think that's gonna be pulled back. So I've been very pleased and impressed with how much we can do without having the patients physically in our presence.
And also I would just add that most of the time you don't really get very much from a physical examination. And you get most of your information from imaging. There are a few exceptions to that, maybe breast, thyroid, whatever, but I think for the most part, you actually don't need to do a physical examination to make a decision concerning operative treatment.
I think one of the barriers that's going to have to be addressed is licensing, because if it's in another state, then there's issues with telemed, and that's something certainly that we face in St. Louis, because Missouri is right across the river. But that's one of the issues that's going to have to be worked out about it, I think.
Why we need a federal license for practicing medicine and not state-based.
I think we also need to be careful of the unintended consequence of potentially continuing to worsen disparities with respects to access to care. Because again, we think telehealth should be easy to implement, but many folks don't have those resources or rely on other family members or friends to try to get them through a telehealth visit.
And Michael, I think that, the point you brought up about post-op, I think there's no, Michael, I think there's definitely some advantages for some patients for post-op visits, but I still have to disagree that the physical exam, to downplay the benefits of the physical exam, I think is a real problem. Since I don't know how many of our residents, when they're presenting a case now, they don't even present the physical exam. They go to the history and the imaging and the OR. And I'm worried that that's a progression that we're going to see more and more of. So, I'm very old-fashioned, but I just think a face-to-face visit allows much more than just being able to examine the patient. It's a rapport that you develop with that patient. And no question, post-op, there's maybe some benefits in the post-operative setting.
Tom Lucetti, I agree with you, but I will tell you, it'd be interesting to ask the young folks on this call that have grown up in a virtual world. And I'll take the spine surgeons, Tom. They don't need to see the patient. They don't need to examine because they operate on the images and the symptoms, but they really don't need the physical examination.
Yeah, but we're talking about real doctors now. We're not talking about spine surgeons.
Well, I appreciate that, Tom, but I think that you and I are old dogs, but we have to stay up with the technology and the changes going on in healthcare. And it is here to stay. I've done my post-op visits, as Mike has, on a virtual platform. I've actually met a patient, I get images, and then I do the pre-op visit virtually. And the patients like it, Tom. That's the important thing. And as we convert to a consumer industry of healthcare, the patients are going to drive it.
Fred, I
think
agree
if
with you.
we
This
do
is
this format again, this is an excellent question for the next time of, is the physical exam necessary? Sorry, Dr. Madura, I didn't mean to cut you off there. I'd never want to cut off an old attending of mine.
Thank you, Danny. Thank you for putting this together too, so I don't forget. But you know, the logical extension of that is what I'm starting to see as the non-MD degreed practitioners start evaluating patients. The patient goes in to see a PA or nurse practitioner for groin pain, and what they need is a physical exam from a general surgeon to tell them they have a hernia and they need to go to the operating room. They don't need a CT scan or an MRI, which is what has ended up happening.
Again, I think this would be, if we do this format again, I'm absolutely loving hearing all you guys give your opinions back and forth. You know, we got 34 surgeons in the room, which means we have a minimum of 40 opinions going around. This is wonderful. But I think we could certainly talk forever about this, or have a poll on is a physical exam necessary, and for what is it not. In the interest of time, let's talk about general surgery interviews. I think the next two questions have to do with selecting residents.
So to summarize, we actually bucked the trend of agreeing with the poll. We actually felt that at least in some form, interviews are going to stay virtual. We talked about the obvious downfall, which is us not seeing body language of the interviewee as they walk out, as they interview with the residents or interact between interviews. But we kind of felt that with technology today, this generation, I mean, the advantage for the interviewee is it's cheaper, it's more convenient. And there are a lot of programs doing a lot of creative things to express and show the culture of their program. They're doing, you know, dinners the night before virtually, or cocktail hour virtually. So our opinion is that this is actually going to stay. Now, will it completely replace in person? We're not entirely sure. I think there's probably going to be some form of hybrid where you cast a wider net at the beginning, lots of interviews, and then selectively bring people back for better fits, which probably is going to go along the question of quality of applicants with USMLE scores. So that we actually would agree that they're going to stay virtual in some capacity.
Interesting. All right, I think LK has got has the poll launched here for us.
So 71% of our attendees have voted. Everyone's trying to make up their mind. I think you made a good case there, because people are close. All right, let's share the results.
All right.
Was the results before? Do you remember?
It was
There they are.
5% disagree and 25% agree. So a shift.
Yeah.
Strong work, Ben. Strong work.
Well, but I guess the question is, are they going to, do we think they're going to remain strictly virtual, or will it be a hybrid? Will it be sort of a virtual and then some ability for people to visit, you know, a smaller group of places after they've been sort of screened virtually?
Our consensus was the hybrid more than likely.
Right.
You know,
That's
again,
why I disagreed. I don't think they're going to stay completely virtual.
No.
It may be
The problem
interesting.
is how is that going to be? How is that going to be monitored?
May be interesting to poll the residents to see how important actually seeing the place where they're thinking of spending the next 5 or more years would be. You know, seeing the physical plant for themselves, meeting the people, talking informally to trainees, et cetera. You know, it's one thing from our perspective, but it'd be interesting to hear what their thoughts are.
We actually did a study of this, of the fellowship interview cycle this last year, a couple of different studies. One from our own institution was we only had 2 weeks to switch from scheduled in-person to virtual late last March when the shutdown occurred. And the survey results, both from our study and from the one that the Fellowship Council has done that's not been published yet, were very positive overall for the applicants regarding the virtual experience. But I think I think the likely reality is that there'll be a mix of virtual and in person, but you want probably being, 20 people in for one fellowship spot, you may virtually interview 20 and have 6 or 7 come in for an in-person visit. And I think that may be the future.
And do you think that the outcome of your match in terms of the performance matches what you thought it would be from the virtual interview?
Well, I think, I don't think it would have been any different for our program, Nat, but the question is, would it have been different for the majority of programs that are out there? And that's the unanswered question, but it's a really important question that you ask, because if you as the applicant are not as savvy about how you present yourself in the virtual setting, making sure the lighting's right, and a good image, and and are willing to engage, in the discussion, then you may not be rated as highly as you would have if you were in person.
So I just see this as this seems to be a huge advantage for the applicants. So I think that, especially for applicants that are interviewing at so many different places, to do that virtual, the savings, the cost savings, time savings for them is huge. And it may be that, we offer an opportunity after the virtual interviews to just come and, for those who have identified your program as something that they are really, really interested in, for an in-person tour, visit, something separate. But the idea of having, I think that some aspect of virtual residency interviews, I think, are going to be valuable and will be seen as very valuable by the applicants.
I do think that we may need to cap the number of programs that the applicants apply to. I mean, this has been a real problem this year, I think, for many of the programs. We'll have to see how it shakes out, and we may not know for a year or two, but I think that, virtual is great. Hybrid might be better, but I think we have to have a cap on the number of programs that the residents can apply to if we go virtual.
Chris, I agree. I mean, ever since it went electronic, the applications have skyrocketed. I mean, at Northwestern, we'd get 1,500 applicants for 6 spots, and that's just ridiculous. And so I think we need to cap it. And I agree that the hybrid might work well, such that you get 1,500 applications or whatever it is, and you virtually interview 100, but then bring 10 back for the final round. And it would cut back. Most of our medical students would interview at between 15 and 20 places. I mean, think of the cost of that. I mean, that's crazy.
Dr. Soper, would that be a match violation, an NRMP violation, if you invited certain people back? Wouldn't that be tipping your cap of that you're more interested in them? Aren't you not allowed to do that?
Well, I think we have to change the rules if we're going to keep going with these virtual interviews. That's my point. I think it makes sense to have a virtual, to narrow it down to a group that you say that these are going to be the 10 finalists for the 5 spots or whatever.
I think it's time for the programs to make the rules. Thank you.
Excellent discussion. We are actually, I'm sure that's LK advancing the slides because we're running a little late, but I'm loving the talk. So here's another one on residency programs. Who is our poll 4 representative, or room 4 representative?
That would be me. This was a very interesting question. I think we could have gone on discussing this for way more than 15 minutes. But our quick summary was that overall, the room was in favor of some sort of competency-based model, but we all feel it is difficult or nearly impossible in our current healthcare environment to implement something like that. Part of the thing, some of the things that are big issues to start off with are just that our evaluation system has a lot of flaws in it. And in order to start a competency-based advancement and graduation from residency, we really have to improve our evaluation methods, figure out where EPAs are going to be a part of this, eliminate bias and subjectivity in these evaluations. Also, there will be big funding issues. How are residents going to leave early and hospitals will lose funding? How will We fund residents who need to stay longer throughout residency. And then how our program is going to deal with the flux and how many residents they have each PGY year, and especially the smaller residency programs will have difficulty managing this problem. There's also the issue of timing of fellowship matches and a whole host of other barriers to this. But I think overall, this is something that would be beneficial in many ways, and we just need to figure out how to get there, and it will be a long time until we figure out how to do it.
Discussion, there's got to be some opinions on this.
I'm a big believer in 10,000 hours to become a master in anything. And just because you're competent at a lap chole doesn't mean you're competent at all aspects of general surgery. So I think you need 10,000 hours and you add that up and that's 4 or 5 years. So I'm sorry, but competency-based might work in some specialties, but not in general surgery, my opinion.
Yeah, I'm kind of with Chris. I know we've been talking about this for what, 2 decades now. I'm not sure how we could possibly make it happen if we couldn't make it happen. And so I'm usually an optimist, but I'm a pessimist that this is ever going to happen.
It's impractical. This is so complicated trying to figure out rotations and how things will be covered and where people will work and everything else. I think it will be virtually impossible in general surgery.
I think some hybrid is possible, and where competency needs to be demonstrated other than the type of exams that we use currently and the 5 years of training, because I do believe that we owe society the responsibility of demonstrating competency, but also to help identify people early in their program that are struggling and need support, and optimize the use of those 5 years to come up with the best product we can. And evaluation is going to be key to that.
I think just to respond a little bit to what Chris Ellison said, the 10,000 hours refers to highly, structured hours of instruction with a specific objective and feedback and a mentor. Most of general surgery training doesn't even come close to meeting those standards, and a lot of general surgery training is probably not necessarily well suited to developing competencies. So I think that to move to a competency-based form of education is going to require a fundamental change in the way we train residents. And it's going to be very hard to graft it onto the current model where we have residents as employees of hospitals doing all sorts of stuff that probably educationally isn't very helpful, and performing a lot of service for the hospital and for the physicians. And so I think that it may be a question of putting our efforts in the wrong direction, in this argument about time versus competency may not be as useful as how could we make training much more competency based, and that means better teaching, better exercises, better evaluation.
I think the question leaves out, it's geared to competence, but young men and women want to be more than a competent surgeon. You need time to figure out what you want to be. What's your career path? Those of you who have gone on to specialties and such, think about when you decided to make your route change. And you need, competence is great, but they also need time to grow up and figure out what they want to do in a career, and you just can't fast track that.
Good to see you there, Bill. Another Ohio State, another
Danny.
person. Let's go. Good to see you. Let's move on to number 5. And who is our room 5 representative?
So I have room 5. So we talked about whether or not surgical residencies would see a change in the quality of applicants once USMLE Step 1 changes to pass fail, which is going to happen here in the very near future. We didn't spend a lot of time talking about pros of that. There probably aren't too many pros that we can see very well from the residency perspective. There certainly are pros from the medical student perspective, however. And we did talk a lot about the cons, some of which actually overlapped with what we talked about with virtual interviews. So it'll be really interesting seeing how the two of these coming together and colliding will change how we interview, how we evaluate applications as well as interview residents. We do anticipate potentially seeing an increased number of applicants because they know that that barrier will no longer exist. And we think that we're going to need to find some alternate way of evaluating candidates, potentially mandating them to take step 2 earlier, potentially mandating reporting of shelf scores, developing some sort of alternate exam, improving evaluations, some different way of writing letters of recommendations that actually allows us to evaluate student performance. And we anticipate maybe this will affect who programs actually take and that they may take more of their own medical students.
Thoughts from the group, you know, does USMLE, I mean, many of you guys have been chairs and program directors. Does USMLE have a predictive value in who's going to be your stellar resident?
Sure. The problem with that is that the sensitivity isn't very good.
Agree.
Meaning,
What we found was that it predicted who would do well on the AB sites.
In some of that, you're gonna, you'll be able to, it will identify some of the people that are going to excel, but not all. And it will identify some people who are great test takers, but can't find their way around a physical examination or making a decision about a patient.
Yeah, I completely agree, Mark. I think that you're going to definitely identify those people that are more likely to pass their boards, but you're going to eliminate, you continue to eliminate some really high quality people for a program that maybe aren't still are test takers, but it'll be great doctors. And I think that the value of highly well-written letter will really skyrocket as we make this a pass-fail exam.
You know, then I think that's the problem. The letters are there's a big disparity in the quality of the letters. So you can't really tell if somebody is highly recommending somebody or just saying, well, stop, don't take this person. I mean, it's very difficult sometimes. But
unless you know the person writing the letter.
That's true. But I think, I can remember when I was applying to residencies, when you applied to the Boston residencies, they would have you take an examination. Do you remember that?
Yeah.
So you go there and you take an exam at the Brigham and the Mass General or whatever, and then I don't know how that all factored in, but you know, I'm afraid that this might be a consequence, that we might see these institutional exams come up again, or the interview will now turn into an oral examination. Or maybe an OSCE, because you can't really know what that person's capable of doing. Anyway, just some ideas. I mean, I do think that steps are helpful. They're not the answer to everything. I agree with everything that Mark Malagoni said. They can be misleading as well, and they don't get the whole picture. But we need some finder to help us find our way in choosing and selecting the residents. And I think pass-fail is a big disadvantage.
LK, do we have the results of this one? Oh. Gotcha. All right, in the interest of time, I'm going to move us to room 6, which I believe was my room. And I'll try to be brief in the comments here, but all of us in the room were concerned that surgical memberships are going to decline after, even when COVID is over. And that we'll try to put it on a positive note that we think there's a real opportunity for CSA to be dynamic and trying to have people see the value of being in a regional general surgical organization. And so I think there's some opportunities here, but we're all concerned that with cost cutting and things like that, that there's going to be a limit on how much that we can join. Anybody else want to make some comments, especially all of you past presidents who love this organization so much, of what you think we'll see happen post-COVID?
I'd like to make some comments. This is the room that we were in, but I think that there has already been a decrease in society memberships, and there's some competition. I think it's really an important time for us at Central to be strategic in our planning and deliver a value that will make our organization attractive, and think about why people are going to want to come to an in-person meeting. Give people an opportunity to network, to have leadership opportunities, have our meetings in attractive locations. Take advantage of our relationship with the journal and things like that. I really think our biggest risk is being complacent and status quo. That we have to use this as a change motivation for us to really think about how we want to move forward. And if we do that, I believe that we could come out of this even stronger.
That's really well said, Jerry. And to that end, I would just make a challenge that everybody who's on this call tonight to make plans to recruit 2 or 3 new members to the Central Surgical this cycle. Fair enough?
Here, here. LK, could you launch the poll? I know we're getting a little bit past our time. I want to be respectful of people's time.
But 90% of the vote is in. A few more people. All right.
All right, we swayed
a few people.
Couple people. All right, bring us home with room 7.
All right. So we'll be brief. I think we it was brought up in our room that the way the question was worded was a bit inflammatory and probably hard to agree with the way it's written. But everybody in the room certainly had things to say, whether they do robotics or not, about the pros and cons of robotic surgery, especially in its current form with the current platform. And a lot of agreement that the major detractors that limit dissemination are the cost and the inability to really prove benefit in a lot of the applications that the robot is being currently used for, and also the risk of new complications or things happening with robotic surgery that would be easily managed open, especially for complex cases. But everyone agreed that new competitors in the field driving the cost down, innovation in the platform, making it more ubiquitously usable, and perhaps expanding the applications that it would be useful for would definitely drive robotics further. And we pretty much all agreed that it's here to stay.
Anyone from the 13% want to speak up and say why they don't think robotics will survive?
We have someone that voted in that direction just now, so feel free to speak up.
It's not always my job to argue against robots. However, I'm willing to make a comment that says, you know, the robotics for usual general surgery, for inguinal hernias, for cholecystectomy, will become increasingly cost prohibitive despite lower cost alternatives. There's nothing beneficial. There is no data to suggest that it's going to improve outcomes. And until we can do that, the robot won't go away, but the expansion will probably slow. That's my feeling.
I'd like to make a comment about resident training in the robot. Our residents love to do robotic cases. They love to do robotic hernias and robotic cholecystectomy. But when they're asked to do an open hernia, they have no idea what to do. When they're asked to do a laparoscopic cholecystectomy, it's a disaster. So I would just say that, you know, we're training people to do what they will do. And if we train them to do robotics, that's what they will do. If we train them to do open hernias like a surgeon should be able to do, that's what they will do. And I think robotics, unfortunately, is here to stay. I think we just need to figure out its place.
Chris, I couldn't agree with you more. I think robotics has its place. I think there's certain operations that are made much easier using it, and there's an advantage. But I think there are a lot of cases where it should not be used. I mean, we proved single incision umbilical hernia repair was bad, or single incision lap chole was bad. We've shown that robotic cholecystectomy is worse than laparoscopic. So let's do a single incision robotic cholecystectomy, right? That's the natural progression of that one.
Wasn't that your study, Matt?
Yeah.
Did we already do the poll on this one, LK?
Yeah.
I think we did.
Everybody else is wrong.
I can't thank everybody enough. I know we're running over a little bit of time. Dr. Mike, if you're still on, I don't want to put you on the spot, but kind of as the current president, do you want to conclude, take us home, anything like that?
Yes, absolutely. And
awesome.
Before we do, I would just like if everybody will look straight ahead at the screen, so LK can get a screenshot of everybody, because we want to probably put this in the next newsletter. I just want to thank Dan and the Young Members Committee for a really great session. And I think it was a terrific idea to put this on, given that you weren't able to do it in person at the meeting because the meeting was canceled last June. This has been a great format, a lot of really terrific discussion and wisdom from the members who participated here and from the past presidents. And so I think we'll have to do this again sometime. It's a great way for the Central to stay in touch and together until we can meet in person, hopefully late July.
Thanks, everybody.
Thank you.
Thanks, everybody, for your participation. Really enjoyed hearing from everyone.
Everybody.
Thanks for organizing.
Stay safe.
Great job, everybody. Go Browns.
Go Browns.
Go Browns. Go Packers.